I'm going to start with a network comparison across states. I'm going to ask whether our in-network price departure is greater in states with more generous fee schedules. We're going to look at utilization in-network versus out-of-network. We're going to take another look at the Affordable Care Act, and then we'll wrap up with what the latest trends in mega claims are. This slide shows the growth in NCCI states of the market share based on payments that are processed in-network. It's been increasing steadily. It's up to 78% in accident year 2016, probably 80% right now. You know, when you're 80% of the market, you can't beat the average, you are the average. However, if we look at things by state, we see that there's a variety of shares. Each state has a bar representing the same years. Each state has the same white line showing the nationwide market share. We can see that many states have shares that are at or above the nationwide, but some states fall significantly short. Most of those are sparsely populated states, but not all. Hawaii, for example, ranks 13th in population density. Now we're going to look at price departure. The price departure is the average of what has been paid to the maximum allowable reimbursement in the fee schedule. Most of the time, that's a discount, but not always. The average over all the in-network transactions is a departure of 14% in 2016. Up a little bit, but it's been pretty stable. The average over all the years shown has been 13%. However, it really gets interesting when you look at it by state. To facilitate that, we've grouped the states into 3 categories based on the size of their fee schedule. To do this, we're utilizing a great analysis by WCRI, which calculates the ratio of the maximum allowable reimbursements in the fee schedule to Medicare. We like using Medicare as a benchmark rather than a straight price comparison because there is some accounting for geographic differences when we do that. So on the left, we have the low fee schedule states, the medium in the middle, and the high fee schedule states on the right. And price departures tend to reflect the richness of the fee schedules. For example, in the low fee schedule states, the departures range from 0% to 15%. In the high fee schedule states, they start at 12% and go over 30%. But it isn't always quite what you would expect. For example, the average Medicare multiple for the low states is 1.25. In the high states, it's 1.82, almost 50% higher. But the average price departure goes from 8% to 17%, about a 10-point improvement. So you can see that the growth in the departure is not commensurate with the growth in the Medicare multiple. Let's look at 3 states more closely: South Carolina, Utah, and Illinois. All 3 of those states have a price departure of 12%. However, the Medicare multiple is 1.4 in South Carolina, 1.5 in Utah, and 1.74 in Illinois. I can tell you that a 12% departure is a much better deal in South Carolina than it is in Illinois. Let's look at the information another way. This slide has each state as a dot color-coded by whether it's a low, medium, or high fee schedule. The x-axis is the Medicare multiple, the y-axis is the price departure. The white line shows a clear tendency for states with bigger Medicare multiples in their fee schedule to engender bigger price departures. But as we saw before, there are states that don't follow that pattern. Whenever you have states that are on a horizontal line, that means they're getting the same departure over a big variety of Medicare multiples. If we look at the service sectors, we see that major surgery only has a departure of 7%. Most of the other departures most of the other services are in the 12 to 16% range, except for complex imaging. That has a 24% departure. It's a very competitive field. You can send your image overseas for evaluation. You know, Medicare has done a really good job of lowering the reimbursement rates for these services, but work comp fee schedules seem to be stuck in the day when everyone was buying MRI machines and figuring out how to pay for it. I don't mean to imply that everything that is out of network is at fee schedule. 34% of the payments are below fee schedule compared to 87% in network. 66% of the out-of-network transactions are at or above fee schedule. Both for in and out of network, it's only 2 or 3% that are actually above. The average over all the transactions out of network is a departure of 5% versus the 13% for the same time period in network. So we're getting 8% more of a discount. However, price isn't all that drives cost. Cost is price and utilization. By utilization, I mean the number of services or the mix of services. X-rays versus MRIs, for example. So now let's start looking at utilization. This slide shows the number of evaluation and management services. Those are the services performed in the primary physician's office in general, and the number of physical medicine services. The blue bars are in network, the gray bars are out of network. In both cases, it's about 10% higher utilization in network than out of network. Now, this is for within 90 days of injury, but we get the similar pattern if we look at 365-day window as well. So there are more services. Let's look at the mix of services. Well, this slide shows the share of established patient E&M visits by CPT code. CPT code is the basis of the billing. There are 5 of them. I've arranged them from left to right in the order of increasing complexity. The distributions are similar except for CPT code 99214, which is the moderately complex category. There, the share is 6 points higher in network, and that comes at the expense of less complicated office visits. So there are more visits, and the mix tends to be somewhat more complex. You know, it's hard to come up with one metric that measures both quantity and mix, but we think we've done it. What we've done is taken all the prices on all the bills and repriced them to a common price schedule that doesn't vary by state, doesn't vary in and out of network. We brought them all on the same price level, so the only difference in the cost then is the utilization. And we can see for these common injuries, minor shoulder, minor knee, lumbar pain, etc., still the same pattern, about 10 to 15% higher utilization. Well, why is that? Well, we're not sure. One reason might be selection bias. Even though we've adjusted for injury mix, within an injury there's a range of complexity. Perhaps the adjusters are steering the more complex claims in network. You know, results have been good. Maybe these added services represent better care. Or on the other hand, maybe there's a greater incentive for physicians in network to upcode because they're starting from a lower price. Or maybe they're just so efficient at scheduling and billing that they realize higher utilization. I know the last time I went to an orthopedist clinic, I got my PT visits scheduled right at the same initial doctor encounter. That was probably worth an extra visit over waiting for me to schedule it myself. So now we're going to move on to the Affordable Care Act. Whenever frequency goes down, we get asked, what's the impact of the Affordable Care Act? The line of thought is workers who don't have health insurance get injured off the job. There's an incentive for them to come in the next day and file a work comp claim to get their medical expenses covered. Furthermore, this line of thought goes, and you might even see more of this on Mondays because there are 2 days prior to that work day for the injury to occur. Plus, people are more active on the weekends. Well, we can't look and see whether the injured worker has health insurance, But we can look at the claim shares by injury day of the week. Sure enough, for the 2 years prior to the Affordable Care Act, there's slightly more claims on a Monday than the other days. These are all slotted by accident date, 18.1%. Now let's look for the 2 years after the Affordable Care Act. No, that's not a typo. The needle didn't move. It's still 18.1%. We didn't see anything. Furthermore, when we restrict this group of states that we do this metric on to those that had the biggest change in uninsured population, we still don't see the needle moving. This slide includes all claims. If you think of the injured worker in the context of a lost time claim, do they file under workers' comp for their medical and indemnity benefits? Remember, these are all injured workers who are out at least 3 days, if not 5, due to the waiting period. Or do they forego their indemnity claim, file under health insurance, perhaps pay a large deductible? So we think that to the extent this type of behavior is going on, it's really mostly limited to medical-only claims because of the remaining incentive on indemnity. And 88% of the medical dollars are on lost time claims. So we don't really see the Affordable Care Act as having an impact on lost time claim frequency. One thing we were worried about was the time to treatment for our injured workers. The concern was when the demand for services went up for physicians as the health insured percentage went up, our workers might have to wait longer to get treated. This slide shows the time to first treatment for strains and sprain cases by year. The left-hand side is the average, the right-hand side is the median. The median hasn't moved in years, and there's no obvious adverse effect on the time to treatment in the average. We were concerned about orthopedists, not from the Affordable Care Act, but there was an adverse trend in the wait time to see an orthopedist. This is for strains and sprains, and it was increasing prior to the Affordable Care Act, both in the median and the mean. Luckily, things have improved in 2015, so we hope that sticks. We'll be updating that information later in the year, but no adverse effects from the Affordable Care Act. Okay, folks, I want to finish with a bang, so let's talk about mega claims. Mega claims, for the purpose of this study, is going to be claims 10 million and above. 10 million is the new 1 million. This slide shows the number of mega claims by accident year evaluated at 24 months. And sure enough, you probably knew it already. There were a lot in 2016. There are 10 here. And this slide doesn't include large deductibles. There's another 4 that are on large deductible policies. The good news is we've started collecting the large deductible data. We don't yet have a history, so I left the slide on this basis, but as time goes on, we'll get the history on the large deductible as well. Okay, so 10, a lot. In fact, it looks like it's a record number, but if we adjust things to a constant dollar basis, we see that we also had 10 on inflation-adjusted dollars in 2006. So it's a high number, but not an all-time high. At first glance, it looks maybe it's cyclical, but I'm not ready to go there yet. I'm sure you're all wondering about 2017. Well, we don't have 2017 at 24 months, but we do have it at 12 months. The white line represents the history at 12 months. 2017 at 12 months, 3 mega claims, down 1 from 2016. Will it stay lower? I think so, but I don't know. If you look at the gap between the white line and the blue line, that tells you there weren't that many claims in history that came in between 12 and 24 months. But 2016 broke that pattern. It wasn't unique only for the number, but the number that came in that pierced the threshold after 12 months. A lot of our research shows you usually don't see $5 million claims become 20 million, but we have to look at these 2016 claims a little more detail to see if there's a new trend in that. Similarly to Paradigm's book of business, we find that 70% of the mega claims are for the result of motor vehicle accidents or falls from elevation. I've highlighted those two categories in the blue bars to contrast them with, on the left, with all lost time claims. On the right is the claims at least 10 million. The ones on the left, all lost time claims, that's only about 12%, so a really big difference in the cause of loss. Similarly, if we look at the nature of injury, we see that most of them, 95%, are for injuries to the brain, head, spine, or multiple body parts. I've highlighted those categories in blue, once again, to facilitate the comparison to all lost time claims, where those categories add up to only about 15%. Now I'm going to switch gears, look at costs by service sector. Where are these costs coming from? Slide's a little different. On the left are all claims, including med only. On the right are claims that are at least $1 million. And I've highlighted two sections, inpatient hospital and home health care. I've highlighted them because A, they're very different on the big claims than they are on all claims, but also because they inflate at very different rates. Hospital inpatient has experienced the greatest price pressure to the workers' comp system over the last several years of any of the sectors, whereas home health care, which is basically labor, has been pretty moderate. But you know, a lot of people are saying because of the changing demographics, there might be a shortage of home health care workers as we have more elderly people and less workers in that field. So if that's the case, wages are going to have to rise in that field to attract more health care attendants, and there'll be a lot of pressure on work comp costs that in those large claims. You know, this isn't just a work comp issue. I myself am wondering, who's going to bring me my soup in 25 years? So in summary, network price departures only partially address differences between state fee schedules. Utilization appears higher in networks. Time to first treatment has been holding steady for primary physicians. Share of Monday claims have not been impacted by the Affordable Care Act. And nearly 70% of mega claims are a result of motor vehicle accidents and falls from elevation. The motor vehicle accidents are the reason why clerical isn't a low hazard occupation. Well, folks, that concludes my prepared remarks and concludes my presentation. This presentation was drawn from several ongoing studies. If you've liked what you've seen, good news, there'll be a paper on each of the topics and many others as the year unfolds. I want to thank you for being a great audience and for listening. This concludes our program for the year. I hope you got a ton of value from this year's symposium, and we look forward to seeing you next year. Thank you.